Afternoon, everyone, and thank you so much for joining the Million Hearts SMBP Forum for September. My name is Rita Lewis, and I work at NAC, and really excited to have all of our speakers joining us today. We have a really great panel ahead of us, and thank you all of you who have joined to listen in. So to get us started today, we want to make sure everyone is aware of the different ways that we will be able to communicate. So we do have our chat feature, so please be sure that as we have our speakers presenting that you submit questions or ideas into the chat and also answering questions. So that'll be a great way for us to hear your thoughts and ideas. Be sure to make sure it goes to all participants so that everyone can see and you can engage with everyone on the line. Additionally, if you would like to share your ideas verbally, you can raise your hand if you have a question or some input you would like to provide. We'll be scrolling through there at the appropriate times to identify you and unmute your line so that you can share your input and ideas as we move forward on the conversation today. Additionally, just make sure to introduce yourself to the chat, get to know your different colleagues, where you're at in different parts of the country. We're really excited to have another robust conversation as we talk about various aspects of SMBP, getting data information from the patient to the provider, as well as reimbursement needs. And getting forward, I'm going to turn it over to my colleague, Haley Soap at the CDC, who will be going over our agenda and our objectives for today.
Good afternoon or good morning. We're thrilled to have our Q3 SMBP Forum today. We do have a great discussion. So some presenters from Dr. Demosthenes and Dr. Humphrey from health centers speaking about their work with SMBP and specifically looking at the processes of patient education and getting the measurements from the patients. We'll have a brief panel discussion looking at some questions and wanting to get your feedback and thoughts. So again, please use that chat and we'll be sure to facilitate the question and answer and open the audio as needed. And then some AMA resources. There's been a new collection of AMA tools and resources as well as the Release the Pressure campaign from the AMA and other organizations that are part of that effort. And then we'll conclude with some updates and resources in our closing. Today's objectives, again, to highlight the techniques to get blood pressure measurements from the patient to the prescribing clinician, discussing reimbursement opportunities for the patient training and clinician's use. That's really looking at what those reimbursement opportunities are, and sharing some new resources and tools, and exchanging the Million Hearts related updates. So we are excited to be part of this event, and I'll now pass it over to Dr. Demosthenes to get us started.
Great. Thank you so much. So I'm Lauren Demosthenes. I'm an obstetrician gynecologist in Greenville, South Carolina, and I wanted to talk to you just a couple things. I have 5 minutes, so I'm going to do a very, very quick overview of some new things that are going on in this space. Next slide. My disclosure is I am the Senior Medical Director for Baby Scripts, which is a digital health company. Next slide. So what I want to do is tell you how we do it here to provide information about setting up remote blood pressure monitoring for patients and educating patients. And this is, again, primarily, this is in the maternity space. And then introduce you to the idea of an automated system to monitor blood pressures in real time that providers can really see on a daily basis. Next slide. So first of all, I think it's really important to know that you really want to use a validated cuff that has been validated in pregnancy. So this is a slide from Natalie Bello from the Columbia University in New York, and this was published in Hypertension. All of the cuffs listed here have been validated. We have had problems here with patients who have not used validated cuffs, so I think it's really important to start out with a cuff that you know is reliable. Next slide. We do our education for patients about how to use the cuff 2 ways, either in person or via an app. So we have access to an app that can go through everything with the patient about how to set up the cuff. So in COVID time, some of the patients have elected not to come in, and we are able to mail them the cuff. They can then open the app and go through how to how to set up the blood pressure cuff on their own. We can also do it in person if that's their choice. So this is how we do it with the company that we work with, but there are companies around the country who are now doing similar things, so this is now available to us. Next slide. So this is how the patients are instructed if they use the app. So they're just kind of given, they open their app and they see these instructions that are step-by-step. Next slide. What I really like about what's coming along using technology is that these patients can then type in their blood pressure number, or they can have a digital cuff where it comes automatically, and we can have a dashboard in front of us where the nurse or the physician can look at this dashboard on a daily basis to make sure that the patient is taking their blood pressure and can look in real time at what the blood pressures are. So this can be done daily. It doesn't take a lot of time. If there is an out of range number, there is a call center that most of these companies have where they will notify the physician immediately of an out of range blood pressure. Those blood pressures are set by the health system, but we follow the ACOG guidelines here for those for preeclampsia identification. Next slide. I think that might be, yeah, I think that might be all. I have some other slides to use for question and answer if people do have any questions. So that's my part, my 5 minutes. Thank you so much.
Yes, good morning and aloha from Hawaii. It's certainly an honor to be able to present to this forum. Just briefly, I'm the medical director at the Lanai Community Health Center, a small rural FQHC that initially started our SMBP program in 2014, and we transitioned to a fully automated Bluetooth-enabled data collection system in 2017 that included both SMBP and SMBG. And the movement to automation is very important for our total population. Data collection is convenient for the patient and the provider. There are no patient logbooks, data transfer or calculations manually. The automation really allows to eliminate human error and partial reporting by patients. So the digital data allows our computers to do what they do best, and that is clean the data, calculate averages, trends, and generate alerts. It also allows us to organize the data into tables and graphs, and it assists in shared decision-making with the patients. The software is easily scalable, so it can handle large populations and many providers. And obviously, with individual results available electronically, it encourages research, and when coupled with other information, it can measure outcomes. I think major challenge in regards to automation, besides the just learning the technology, is the cost to automate SMBP and data collection. And the other challenge is actually to have the blood pressure vendors work with us to build interfaces to get the digital data into information systems. There's really been very little evidence that health plans are willing to cover the cost of automation. I know there's CPT codes, which will be related later, but those do not cover the cost for the automation of SMBP, and would point out that SMBP is not a HEDIS measurement, so there's no evidence that it will be incentivized by quality metrics. Our existing guidelines and knowledge is largely based on office blood pressures. SMBP is best correlated with ambulatory blood pressure monitoring as a surrogate for ambulatory blood pressure monitoring, which has been shown to be a better predictor of cardiovascular outcomes, but is very inconvenient. So we look at lowering blood pressure improves outcomes. The treatment really needs to be more about the number of medications required, side effects, patient's preference, and cost, rather than having a defined hypertension metric such as 140/90. Can I have the next slide, please? Our community health workers are the backbone of our program. With the eHealth digital divide, they provide setup and train patients, problem solve on gathering SMBP data, and are the health coaches and connectors between office visits. We have seen a tremendous variation in the SMBP measurements on individual readings and subgroups. Some elderly appear to have wide variations from day to day of their blood pressure. Looking at circadian rhythms, which is important, some patients have a 20-millimeter drop from morning to evening, while other patients have none. We recommend 3 readings as recommended by Million Hearts, a minute apart, as some patients actually have consistent elevation of blood pressure with that initial reading and putting the blood pressure cuff on. It is ideal to check home blood pressure cuffs against calibrated office blood pressure cuffs. Multiple readings in both arms are recommended, and there is variation from moment to moment, so the correlation won't be 100%. Most certified blood pressures are accurate out of the box, and we do not require validation of the blood pressure cuff prior to starting SMBP, but attempt to complete the validation once the patient is available in the office. We also do see lemons and equipment failure over time. My guess is about 1 out of every 50 cuffs does not work as designed. Cuffs are likely to need to be replaced every 2 to 4 years, but I'm not sure if there's been any specifics about blood pressure replacement. For populations, SMBP readings are lower than office blood pressures. That is certainly not true for individual patients. There's a clear advantage of not abandoning the office blood pressure readings and complements the SMBP and may identify equipment failure or change in status. There may be some clinical significance for those patients that have large fluctuations in daily SMBP or fail to have circadian rhythm. We have a lot to learn in the management of hypertension using SMBP, and population studies of SMBP data will alter the management of hypertension. That's my short 5 minutes, and I will turn it back over to Rita.
Thank you so much. We really appreciate both Dr. Demosthenes and Dr. Humphrey for sharing what both their health centers are doing to, help patients with their SMBP devices and getting that information back to their medical record. We do have a couple of these discussion questions on the screen. So for attendees, please, take a look at these, add some insights into the chat, or raise your hand if you would like to share. But we do have some questions in the chat already that we'd like to share. So for both Dr. Demosthenes and Dr. Humphrey, there's a great question here from one of the attendees, and we would love for both of you to answer. The question is, are there any concerns about patients sharing their cuffs with family members and not getting measurements that are actually that of the patient back as you're collecting data?
Do you want me to take that first? Absolutely. There's particularly in our with patients that are not used to using technology, there's a huge amount of human curiosity in regards to blood pressure. And when we first started the program, it was like Christmas, and everybody went home and played with their blood pressure cuffs. Getting blood pressure at the right time of the day is important. That's one of the reasons you actually have to screen out some of the readings in the blood pressure cuff if it doesn't look like it's standardized. We certainly educate patients not to share their blood pressure cuffs. The blood pressure cuffs, they can have 2 different patients on the same blood pressure, patient 1, patient 2, and they do have systems to allow guests to measure their blood pressure, so teaching patients how to use it. But the computers allow you to pick out some of these variations, which helps to eliminate those situations.
This is Dr. Demosthenes. So, yes, that would be a concern. I guess a parallel that I'm thinking of is, as an obstetrician gynecologist, we will have people bring in a blood sugar log on blood sugars, and we have sort of that same question of whether or not they're accurate, or if patients are just writing in blood sugar. So I think a lot of it is just trust with your patient, education, and trying to help them understand that it's in their best interest to be honest about the blood pressure, because we're just trying to gather vital sign data that's important for their health.
Great, thanks so much for your insight. And for the discussion questions up on the screen right now, attendees, please make sure you're thinking about that, sharing your insight, or raising your hand so we can get to you. But we do have another question that we want to answer from the chat. So the question is, how do you go about calibration of the monitor, or is this particular step not done in getting patients their devices? And that's for both Dr. Demosthenes and then Dr. Humphrey.
So, I mean, I can take that first. So if the patient is in the office or in the hospital, we can just teach them how to use it, and then we can make a comparison with the blood pressure cuff that's in the hospital or in the office to make sure that it's accurate, and before they leave, just sort of do a check that they know how to do it. Now, in our new virtual world where we can actually mail them the kit, that's why we're using the standardized out-of-the-box ones that somebody might that have been validated. Again, I don't know what you would do if you told a patient to go buy a cup on their own, because it's sort of the same thing. But that's how we're doing it here, and so I would be interested in Dr. Humphrey's experience, if it's all in person or not.
My first comment is to make our system work, why we have all patients on the same blood pressure cuff, so the interface works. But that's also really important cost-wise, because we've been able to get a discount. Blood pressure cuffs cost $35 instead of $70, and that was through some influence from the health plans. But also our staff needs to know about the app and how to load the information and all the different technical aspects on managing that. And we definitely when we do get an office visit, why we have everybody educated to go ahead and validate it. As I said, the cuffs are automatically calibrated, so when you start using them, they are supposed to be accurate out of the box. And as I said, most of the time it is. When we see real inconsistencies between what we've previously seen in the office and what the patients are reading at home, we'll bring patients in to see if the calibration is accurate, or if the variation from office, the white coat hypertension, or other influences are occurring, and the home blood pressure readings are probably the more accurate of the two.
So I'm also going to ping in here Meg Metter from NAC. She is going to kind of share some insight that we've gotten from the health centers and networks we've worked with in some of our projects for the Million Hearts work here at NAC. Meg?
Sure, absolutely. So I'm glad to just share a couple of insights we learned when we did a big SMBP project a few years ago. So I think this is going to be no surprise to folks, but definitely you need to tailor your approach to the patient. So we had a lot of patients where in-person was best, and using teach-back methods, definitely was important. I do think we've heard a lot of health plans who just send devices out to patients without any kind of instruction, and that's really not even an evidence-based practice. I really am curious about the app. I think that's fascinating. I would also say, with regard to question number 2, again, sort of tailoring how patients return measurements to their particular capabilities or preferences is very important. So I know in this environment we're looking more towards the digital, and I think that's good. You can also get devices with memories, that can remember up to 100 readings. And so if a patient isn't comfortable with an app or doesn't have access to a smartphone, you can get a device with a memory and simply have them, record their readings at the right times of the day. and then either bring that device into a face-to-face visit, or even now you can show that memory virtually on a virtual visit, and that, that accommodates numerator compliance for different quality measures. So just think about, different ways that you can accommodate your patients with the different devices. Definitely a device with a memory. Bluetooth is good too. I would say we also had folks who didn't feel comfortable with the app, but a lot of the apps work like a Fitbit, where they don't actually have to do anything. The medical assistant can actually, sync that app when they come into a visit. So there's just some different options to think about that, that allows you some flexibility to tailor it to the needs of the patient.
Yeah, this is Joe. Yeah, and just briefly, our community health workers all have tablets because we do run into the situation where there's not a smartphone in the family or otherwise somebody to help with uploads. So they're able to upload from the tablet into our information system with a home visit. And we also get families involved because our patients are elderly. A good percentage of them don't speak English as a primary language. And so the challenge of getting data and getting that training done is significant. It takes a significant amount of time.
And so this is Lauren, and I think one other maybe lucky thing is in the maternity space, it's a population whose age is really pretty used to technology, and so that's made it a little bit easier of a transition. Most people have a smartphone and are used to using apps and technology to gather information and education.
And thank you so much for sharing that. I think there are some questions in the chat, talking about the technology piece and, where are some of the challenges that come into not only dealing in a very kind of digital time right now and working with patients remotely, but also some of the data collection pieces. So I think to kind of tie in some of the questions around data collection and the technology piece, what are different ways that you're seeing patients submit their data that may be unique ways or kind of one-off ways that you're getting the readings that may not be strictly technology. Because I know, as you mentioned, I think it was Dr. Humphrey mentioned that not everyone in the household may have a smartphone, maybe one person does. So how are people navigating that challenge of limited technology and getting the readings to the clinician?
Joe, I can answer that first if you'd like. So first of all, if the patients really don't have access to the technology, what we really have either asked them if they're not going to be able to do a video visit, we are doing phone visits where we just can simply ask them, what was your blood pressure? I don't think that's quite ideal. We do not have every single patient using home blood pressure monitoring. There's still some that just aren't comfortable with that, and so they're just coming in. We have set up something at our health system during COVID that's a drive-through blood pressure where we just check it from the car, which it works for some people. So we offer kind of a menu of options so they can still come in person. They can do it digitally. We can do it by phone call. They can drive through. So we have all of those things going on at the same time.
Yeah, and I think what we certainly learned early on, originally we had our patients, we've always had our patients with insurance buying the cuffs to cover part of our costs, and that has not been a significant barrier as long as patients understand that. But it really was like Christmas. The first 6 months was great, and everybody brought their meters in, or their cuffs in, and we uploaded the data, et cetera. But then it gets back to what Lauren said, and that is patients like to self-report, and it left us with no data. So that is a major sort of barrier because they either forget how to do it or we don't follow up adequately. We do, we've attempted, and we've got virtually probably 90+% of our patients with home blood pressure monitorings, or even more. We're really not using office blood pressures very often. But the patients will report they're doing well, and that's not adequate. So we've been struggling with that to get the data in for 100% of the patients rather than those that are cooperating. Community health workers really are key to being able to do that.
Thank you so much for sharing that. I do want to highlight one comment that we had from one of the attendees, and I'll have a final question for the panelists. So one person mentioned that many of their patients keep the paper logs and sometimes take a photo of it and they text it to the staff prior to their upcoming phone visit with the PCP. So that's a way that someone has shared that they're sharing or receiving the blood pressure readings. But one question that we've seen a few times in the chat, and I think it'll be our last one, which we can move on if our panelists could answer, what are some of the ways that the CUPs are being funded, if there are short-term or long-term funding opportunities or grant programs to help patients obtain these SMBP CUPs?
This is Lauren. I can take that first. So there are around the country different models being used. So I know in some states, health systems are actually paying for this, for the service, because they see the benefit in pregnancy for early detection and reducing readmission. So there are some health systems that actually take on the expense. In DC, there are a few Medicaid managed care companies that are paying for it. So it's going to the insurer to pay for it. In South Carolina, our DHEC bought a lot of cups for us to use just during COVID. But I think more and more, and we may get into this, but there's also some reimbursement that is, there are codes for setting up the cuff, and then there are codes for charging for more than 15 days of monitoring in a month. And so, that's another way to gather some reimbursement to pay for the services.
Yeah, this is Joe again. Yeah, with our the barrier that I ran into is credible. Yeah, when we started, our Medicaid approved it because it was medically necessary. I sent in the literature and got an authorization and never collected a dollar for the health center. Blood pressure cuffs are on the medical side. They're durable medical equipment, and we buy our blood pressure cuffs from the pharmacy, and the pharmacy can't collect money for durable medical equipment. They can only collect on the pharmacy side. It's been a barrier. One of the health plans just gave us a $6,000 grant and just said for the next couple of years, please buy blood pressure cuffs for your patients that are on Quest. As I said, it hasn't been a real barrier for the private pay patients at $35. If it was over $50, I'm sure that would be. And the health plan had helped us to arrange with the supplier to basically get it at a discounted price so that we don't lose significant amount of money on there. I think there's one other comment I have, which I think is really important, and that is we are now partnering with actually off-island pharmacist who's going to take an active role in working with our community health workers and through protocols being able to do medication adjustments, I think similar to the way Ohio State was working with pharmacists. So that's another option to think of as far as collecting data and managing patients.
Great, thank you so much. I really appreciate both of you sharing your insight. I know we have some great conversation happening in the chat, so both Dr. Demosthenes and Dr. Humphrey, thank you again, and feel free to address the comments or share more insight in the chat, but really appreciate you both, and also Meg for chiming in and answering everyone's questions. So next up, we will move on to our AMA colleagues to discuss some of the different resources that AMA has available and some information on some of the other reimbursement codes and CPT codes that are available for SMBP. So Dr. Wozniak, you have control, and thank you so much.
Thanks, Rita. Good morning, everybody, or afternoon. I'm Greg Wozniak. I'm the Director of Outcomes Analytics in the Improving Health Outcomes area, the Health Outcomes Group at the American Medical Association. And I just want to sort of maybe emphasize on what you just heard were great examples of two providers and clinics who are really ahead of the curve And one of the things that we with the AHA found was that there's a lot of clinics and providers that are behind the curve. And the result of that was putting together a policy statement that really brings together the evidence on using self-monitored blood pressure at home. And I do want to emphasize that at times there's a lot of confusion about self-measured blood pressure, self-monitoring, and whether or not that's at home or at some other sites, kiosk, et cetera. But the focus is, and what you've been hearing, is about monitoring at home. So I want to acknowledge some co-authors. Daiichi Shimbo from Columbia University led the effort of putting together a policy statement along with myself at the AMA, as well as Mike Raycott at the AMA, who many of you may have heard speak at earlier forums. So I just want to acknowledge their contribution. So what I want to do is talk a little bit about some of the components of the policy statement. And the policy statement really brings together evidence around using SMBP at home. And the various sections of the policy statement cover the following areas. And we've heard a lot about techniques and the reason for using SMBP, which again is very consistent with what's in the policy statement, very consistent with the evidence that's out there, both in terms of the 2017 hypertension guidelines, as well as some other evidence around the use of SMBP. One of the things that we also heard was the use of validated devices, and AMA and HA strongly were very strongly looking at proposing evidence base around use of validated devices. And what we did was we put together an independent entity that actually developed a criteria and applied that criteria and identified devices that are validated. And this is both in-office and out-of-office devices. And currently, there's 16 blood pressure devices from 3 different manufacturers that are on the validated list that you can find at validatebp.org. And there's been multiple submissions for other devices to be assessed in terms of their validity, and again, having various devices being reviewed by the committee and then being added to the device list. So this is the first version, came out in April, but there's, I don't know the number exactly, we're getting applications daily for additional devices to be reviewed and assessed. In terms of the effectiveness of using SMBP, there's clear evidence that there's an association with improved blood pressure when the device is utilized along with co-interventions and other components. Keep in mind that we just don't want to hand out the devices, and I heard Dr. Humphrey refer to people thought it was like Christmas and how they sort of responded to getting a device and the use of the device. But it's important that it's more than just the device being distributed and being used, that it requires counseling, education, along with the device itself. But in terms of the effectiveness, we see reductions of blood pressure as SMBP and improved blood pressure control versus usual care, along with co-interventions such as phone support, patient education, counseling of patients that go along with delivery of the device and the use of the device. In terms of cost effectiveness, the studies have shown that SMBP is cost effective when used with co-interventions. And one of the, I think, last points that Dr. Humphrey made was the use of pharmacists and how they might play a role where they're titrating drugs, they're counseling patients. So not just the in-office staff or the care team, but other providers as well that aid in the development of educational materials and providing counseling and education. And again, that's being one of the co-interventions that, along with the device, are very effective in reducing blood pressure values. We also heard about barriers, and you can think of barriers in 3 buckets. There's care team provider buckets, a bucket of barriers in terms of at least the interpretation that protocols are too rigid, that it's time consuming, they don't understand the educational benefits or may not have the materials that can be provided to patients to educate them on the use of SMBP. And then there's the out-of-pocket costs. And I'll talk in a minute about some CPT codes that have already been mentioned about reimbursement for patient education and use of SMBP. There's also, again, there are provider benefits, or excuse me, barriers and health system barriers. We've already talked about validated devices and accuracy of devices. There's also system level about how do you collect the measurement and transfer measurements into the clinic for providers to be able to use. And again, system-wise, any infrastructure or co-interventions that may not exist that are difficult to implement or have sort of co-barriers with patients and or providers. In terms of the CPT codes that were mentioned, there are 2 CPT codes that went live in 2020, January 1, 99473 and 99474. 99473 is a CPT code that can be used in the clinic to train, and it covers training and device validation, or calibration, excuse me, and using a validated device so that you can submit that claim or that CPT code once per device. And again, there must be a validated device being used and often used, again, prior to initiating SMBP with patients receiving training for the first time. So this is sort of a one-time, one patient, and I believe it can be submitted once a year. I'd have to check that, but I'm pretty sure that's the timing of this. The second CPT code, 99474, relates to the reporting of the devices, the accurate or appropriate procedure followed in measuring BP readings for the patient in terms of how often they're taking their readings, how many times a day, how many readings there are that have to be reported. It's a minimum of 12. You don't need 15 days worth. Collecting data that's reported by the patient or caregiver to the physician or, again, the care team, the qualified healthcare professional, and reporting an average. Again, the average systolic and diastolic blood pressures are what's recommended for evidence and in the evidence base, and not just individual readings or a series of readings, but actually using the average. This CPT code can be submitted once a month per patient, assuming, again, they meet the requirements for the use of a validated device, a minimum of 12 readings, and the reporting be done in a manner that they can be documented in terms of average systolic and diastolic, and then there's a treatment plan communicated to the patient. Earlier it was mentioned about whether or not the self-measured blood pressure readings could be used as part of quality measures. And in fact, this would be a whole other session. The quality measures, both HEDIS and the other related NQF and measures that are out there now, are moving towards the availability of using the home measurement within those constructs. So more to come on that in terms of the new HEDIS measures actually provide much more flexibility in terms of using the measurements that come from the self-measured devices and from patients. So in closing, happy to take any questions, but again, really glad to hear how the 2 examples of clinics that are really utilizing evidence and relying on SMBP and really outside sort of what other folks are doing, but great examples of best practices. Rita? Happy to take questions.
Great, thank you so much. I'll ask this one question in the chat, and then we'll move on to get to Linda, and then we'll take a couple more after that. But there's a question that I'm sure many people are thinking, but since the validated device list, unvalidated BP, is still limited, are devices that are valid unvalidated lists from other countries considered validated for billing codes? And are any of the validated devices that are on for this country for the extra large arm sizes?
That's a very good question. I'm not sure. I don't believe that. I don't know. And one of the problems that comes up with validated devices from even Canada, those devices may not be available in the United States. There's various numbers or brands with their model numbers or serial numbers that may not be available or equivalent to U.S. devices. That's one issue, but that's a good question in terms of defining what validated is in terms of the CPT code.
All right, thank you.
Yeah, this is Joe. Yeah, I'd take the answer to the large cuff. I've looked for that. Most of the cuffs have up to 16.5 or 16 plus inches arm size, but the large cuffs are really not available. I've not seen anything as we have in the office where there's graduated cuff size. But in the morbidly obese, even in the office, it's an incredible challenge to get adequate blood pressure with a large cuff or a regular cuff.
Yeah, hi, this is Linda Murakami. I'm with the AMA, and I'm actually going to be speaking next. There is a Welch-Allyn device called Welch-Allyn Home. It's a home blood pressure monitor, and it can come with, you have to order it separately, and I honestly don't know the cost, but there is an extra large cuff that can be used on this particular device, and it goes up to 21.25 inches. So it's for an arm circumference of 15.75 to 21.25 inches, which is 40 to 54 centimeters.
And very briefly, I have Mike Raycox off mute to chime in as well.
Can you hear me, Rita?
Yes.
Yeah, so what Linda says is exactly correct. The Welch-Allyn device has an interchangeable cuff system to go with a wide range cuff. For $15 to $20 retail, you can typically get an extra large cuff that, as she said, goes to 21 inches. We're hopeful that some of the other manufacturers that have XL cuffs, and there are not many, will be submitting to the independent review committee to be listed on the VDL. Just wanted to very quickly, because I know we're short on time, touch base on Greg's. On the question on device validation and using U.S. VDLs versus international VDLs, the CPT code doesn't specify U.S. only validation versus international, and in fact, most of the validation protocols are international protocols, so you should be able to find a validated device either on the Canadian list or on one of the many European lists or even Australian lists, but to Greg's point, you have to make sure that the model number, which there are several, match up. So that, but you should be able to do that in many cases. So those lists are much more comprehensive than the new, very young U.S. validated device list that will hopefully be catching up soon. But yes, you can use those other countries' validated device lists if you can match the device model number. And I'll stop there for time.
Great, thank you. And we're going to move on to Linda Murakami. I have your slides up, so we can go on and move on to your presentation.
Thank you, Rita. Okay, so I'm just going to spend a short amount of time here talking about a new website that we launched in late June. So we, at the AMA, developed a 7-step self-measured blood pressure quick guide. You can see the website here listed on the screen for you, and maybe we could throw that in the chat too, so you can just hyperlink and grab it right away. Once you are in there, you can also download it as a PDF. I know that people do still like that paper to touch and hold in their hands. So this quick guide was developed to help, health centers and primary care offices that are trying to manage hypertension with that blend of virtual and in-person visits. but we know it's important to monitor patients' blood pressure, you know, at home, no matter what time, but especially, you know, I think during this period of time in our lives. So the guide outlines how you would identify patients for using self-measured blood pressure, knowing that not everybody needs it. And there's information on the validated devices that Greg and Mike were just talking about. There is, you know, the link to that website that he alluded to earlier. And then there's more information on patient training, which is extremely important for patients doing their blood pressures at home, which we've heard, and how to communicate the results, or different methods that they should use to communicate the results back to the provider office. There's also some information on managing those results and interpreting them to interpret the patient blood pressure results, you know, for the provider, so that we can continue to use this as a self-measured blood pressure monitoring tool. There's also links to tools that include our infographics for patients that shows them how to properly prepare themselves and how to properly position themselves for the measurement. There's also a link to a short patient training video. And both of those come in English and Spanish. And there's a recording log for the patients to write down their blood pressure results. There's a document on the cuff selection, because we just talked about how important cuff size is. And then there's the information on the CPT codes that Greg was talking about, and a downloadable PDF with that CPT code information. So the website, we've seen a lot of activity since it launched, with like over 1,600 views by healthcare professionals nationwide. So check out the website when you can, and we hope you find it useful. We always appreciate feedback, so let us know how you feel about it and how well you're using it. And now I'll pass it, oh, I guess we have a minute for questions if anybody has any. So, but Rita, you'll let me know, and then I'll just pass it off to Lauren, my colleague at the AMA, to talk about the release of pressure.
Perfect. Thank you so much, Linda. And next up, we'll have Lauren Barbian, who was talking about the Release the Pressure campaign, as Linda mentioned. And Lauren, I believe you have control over the slides now.
Thank you so much. My name is Lauren Barbian, and I'm a Marketing and Communications Manager for the AMA's Improving Health Outcomes team, along with Linda, Greg, and Mike. Today, I'm excited to provide a brief overview of our Release the Pressure campaign, with the goal of arming you all with the knowledge and assets to help us further spread the word and expand our reach. The AMA is committed to prioritizing health equity, and this campaign centers around reaching Black women who are disproportionately affected by high blood pressure compared to white women in the U.S. To help fill this gap, we launched the Release the Pressure campaign in June 2020, following a soft launch in March. Release the Pressure is a year-long collaboration with Essence Magazine and a diverse coalition of healthcare organizations who we call our Release the Pressure Heart Health Squad. The coalition includes the AMA, AMA Foundation, American Heart Association, National Medical Association, Association of Black Cardiologists, and Minority Health Institute. Our mission is to partner with Black women to take preventative action to protect their heart health and be part of a movement for a healthy blood pressure. The campaign officially launched with an advertisement in the 50th anniversary issue of Essence Magazine, a series of articles on essence.com, as well as a virtual panel at the Essence Festival of Culture. And we also launched a campaign microsite, releasethepressure.org. And this site encourages visitors to take our Heart Health Pledge and download several resources which are focused around SMBP. Our Heart Health Pledge focuses on 4 important steps, including committing to setting a blood pressure goal with a healthcare professional, monitoring your blood pressure at home, activating your wellness plan, and checking in with your squad or friends and family virtually. We aim to have more than 300,000 people nationwide take the pledge from now until February 2021, and that includes African American women, their friends, their families. It's not only limited to women, although they are our targets. We're also encouraging over 75,000 people to download our SMBP resources, and for over 40,000 to join and engage in our upcoming virtual events, which will be planned in late fall, winter, through the end of the campaign, of the first year of the campaign in February. And then the next slide just shows our Release the Pressure Coalition, so you can see all the logos there. And then the next few slides also show some resources that we developed with the AHA as well as our clinical experts. Or here's the campaign landing page, and then we also have some resources we'll go through. But this is the campaign landing page where you can go release the pressure, and then you can take the pledge. And then if you go down to the bottom, there's the different resources. So these were developed in collaboration with the AHA based off of resources from our high blood pressure consumer campaign, and we made them culturally relevant for our Release the Pressure campaign targets. So we have this chart that shows proper home blood pressure numbers. We also have these resources focused around monitoring your blood pressure at home. So we have this, we encourage you to come check out these resources. We have this great SMBP training video. We also have a blood pressure measurement log as well as this graphic that you can, that patients can use to learn proper blood pressure measurement at home. And then we also have a variety of lifestyle resources that were developed in collaboration with AHA, and also some articles and resources about checking in with your squad and staying connected. So we encourage you again to explore this microsite, releasethepressure.org, check out these resources, and share them with your patients in your network. So we already have a strong coalition of collaborators to help us make an impact. As we won't be able to help, and we won't be able to reach our goals without the help of other leaders in the healthcare space like yourselves. We've already engaged many organizations to amplify our campaign assets and help raise awareness to their networks, and we'd love your help spreading the word too. So you can do this in many ways, such as sharing the pledge and related and our links on your social media sites, posting link to releasethepressure.org online or in your newsletter, and just educating your squad, so your friends, your families, patients, colleagues, and then most importantly, joining in our heart health movement by taking our pledge. It just takes a minute. So after this call, we'd love for you all to go take our pledge and help spread the word. And then please don't hesitate to reach out with any questions or to discuss the campaign further. We're always open to jumping on a call to brainstorm ideas, and we can discuss future or further collaboration opportunities as well. So we're so appreciative of the support of you and your teams, and thank you very much to Judy, Haley, Rita, and everyone for the opportunity to present today. And that's all I have. Hope everyone has a good remainder of the week. Thanks so much.
Thank you so much, Lauren and Greg and Linda, and also Mike for chiming in. Glad you're able to join us. So we're going to move into our final updates for all of our resources that we've talked about and other things that we have upcoming. Just want to do a quick reminder to remind everyone that we do have the CDC Million Hearts SMBP webpage. There are a plethora of tools and links and resources that are available there for you to check in and tap in and get everything to share with your team, along with everything you've learned about today. Additionally, we want to remind everyone that we do have all of the resources and slides from our June SMBP forum. We talked about maternal health, which was really popular amongst all the attendees. So remember to check out the Healthcare Communities resource page, as well as we've now uploaded that recording to the NAC Million Hearts YouTube channel. So we'll make sure to have this available in the resources on Healthcare Communities, and try to get this into the chat so that we can share that, so you can share with other colleagues to listen to that recording on YouTube. Additionally, there's an awesome resource on Healthcare Communities. It has a long list of tons of websites and resources for you to easily access. It's a PDF document so that you can share that. It has the links to the resources on this page and others to make sure that you're getting all the information that you need. Next, we'll have Haley talk about COVID and cardiovascular disease.
Thank you, folks. And yes, we will have the slides up, and there's also a new handout that's a PDF of the resources with links. So check that out, and it has it broken down by easy access. Just briefly, there has been a couple new MMWRs coming out from CDC. Hopefully folks are aware that in the past 10 weeks, following declaration of COVID-19, the national emergency visits to the emergency room have declined for heart attacks and strokes. We see 23% among heart attacks, 20% among strokes, and this is concerning. Folks are not using the ER as we expect them to at this time. So We'll hear in a moment from Kenitra Joseph on a new communications approach with some PSAs to help address that, but we're really trying to help folks be aware that going to the hospital is essential, especially when those symptoms are coming forward. And of course, people with cardiovascular disease are at higher risk for serious illness as a result of COVID-19. So just a couple of resources and the link to MMWRs below. And then I'll hand it off to my colleague, Kenitra Joseph, to talk to you about the PSAs and how we can help spread the messages. Kenitra?
Thank you, Haley. As several of you may be aware, we launched 2 PSAs about managing heart health during COVID-19, including an important message about seeking emergency care for heart attack and stroke symptoms. Those were launched in August. Thank you to NAC, along with the Million Hearts team, the CDC Foundation, and several Million Hearts partners who played a critical role in launching the PSAs. You see on this slide some of the metrics from the month of August, including significant number of impressions via social media, thanks in large part to NAC and many of our partners. Right now, we are still continuing promotion, including e-newsletter promotions, some planned earned media outreach, including a satellite media tour and pitching in October, and a USA Today insert coming out soon. So as we approach flu season, we are continuing to leverage the PSAs and promote these important messages. On the next slide, you will see that as we continue to have additional content coming out of our ongoing promotions, you are welcome to access the key messages, links to those PSAs, social media graphics, and copy for any of your digital channels if you want to leverage them to promote heart health during COVID-19 and the particular message about seeking emergency care. As we get additional content from this ongoing outreach, we will continue to update that link in that toolkit. Links will be available in this PDF that you'll receive. Thank you.
And next we'll have Judy Hannon to help us wrap up talking about cardiovascular disease and the flu shot.
Great, thank you. Just wanted to mention a article that's out in the Annals of Internal Medicine, and you see the infographic here about people who are hospitalized with the flu. 1 in 8 end up having a sudden heart complication. Of those, 1/3 end up being admitted to the ICU and 7% die. So enlisting all of your help in getting flu messages out. And Rita, is that the last slide? Can I just go right into, and here's some more information, the bottom line, make sure that you make a recommendation about a flu shot. There should be ample supply this year, and we really need everybody's full court press on that. With that, if you have questions, updates, please share them. I want to thank Haley and Rita for putting together another awesome session, and our speakers. Thank you very much. And more importantly, the over 120 some attendees really appreciate your time on this. We are very excited about how much energy there is around SMBP. I did see that we didn't answer all of the questions, and especially some about some of the legislative approaches to getting coverage. That might be a good one for our next topic. I know there is some activity going on nationally. We can speak about what we've done with OPM, AHA might have some updates, and I know there's a lot of state and local activity going on. So continue to bring your questions forward to us, and really appreciate everybody's time and their attention today. Thank you very much. Have a great day.
All right, and thank you everyone. Just a reminder, our next SMBP forum will be Thursday, December 10th, 2020. So share the word, get other colleagues to register, and thanks so much, and we look forward to speaking with you in December for our 4th quarter meeting.
And thank you, Rita. I don't know if that audio is being carried on, but perhaps we'll follow up through email.
Yep, I'll give you a call. There's still people logging on.
Wonderful.
Thanks
Thank you so much.
Haley. Bye now.
Thank
All right,
you.
bye, everyone.